When a patient needs major vascular surgery, say repairing a giant aneurysm in their aorta, the surgeon's focus is on the plumbing, right? The blood vessels. But here's the thing. The biggest danger, the number one threat to that patient's life, often isn't the vessel they're fixing. It's the heart. So let's dive into why this specific type of surgery creates such an intense, high-stakes balancing act for our most vital organ.
This ancient quote, it absolutely nails the core of the issue. It's not just about, say, a blocked artery in the leg. It's about the kind of patient who gets that blocked artery in the first place. These folks often have atherosclerosis, the condition that hardens and narrows arteries, not just in one spot, but pretty much system-wide. So the same disease that's causing the trouble in their aorta has likely been quietly setting up shop in the arteries of their heart for years, creating this incredibly fragile situation.
And this number, wow, this really puts the risk into sharp focus. For the most complex, high-risk vascular surgeries, the chance of a major, life-threatening heart problem can shoot up to almost 22%. Think about that. That's more than 1 in every 5 patients. So understanding and planning for that risk isn't just a good idea, it's everything. Okay, so to really wrap our heads around this, we're going to follow the entire patient journey. We'll start by looking at why this is a perfect storm for the heart. Then we'll define the exact threat doctors are on the lookout for. After that, we'll see how they size up the risk beforehand, what happens inside the OR to protect the heart, and finally, why the most dangerous part of the whole ordeal might just be after the surgery is already over. So what makes this a perfect storm? Well, it starts with a patient who, as we said, already has a vulnerable heart. Then you throw the massive stress of surgery into the mix. And I'm not just talking about being nervous. This is a full-on physical assault on the body. Your blood pressure and heart rate can swing wildly, what doctors call hemodynamic changes, and your body's inflammation and clotting systems go into overdrive. It's that exact combination that creates the perfect conditions for a cardiac disaster.
All of this leads us to the number one threat the medical team is constantly guarding against. It's something they call a MACE. Sounds serious, but what does that actually mean? What exactly are they trying to prevent?
Okay, so a MACE is basically an umbrella term for a few very serious problems. The one we all know and fear is a myocardial infarction, a heart attack. But a MACE also includes other dangerous stuff, like the sudden start of a chaotic, irregular heartbeat, known as atrial fibrillation, or even acute heart failure, where the heart just suddenly can't pump enough blood to keep up. Now, here's a distinction that is absolutely critical. We usually think of a heart attack as what's called a type 1 event. That's when a piece of plaque in an artery suddenly ruptures and causes a clot, a sudden blockage. But after vascular surgery, the bigger threat is actually a type 2 heart attack. This isn't a sudden clog, it's an energy crisis. The huge stress of the operation makes the heart work way, way harder, demanding way more oxygen than its already narrowed arteries can possibly deliver. It's this supply and demand mismatch that ends up damaging the heart muscle. And what's truly terrifying is that one of these events can kick off a horrifying cascade. It starts with a heart attack, which weakens the heart's ability to pump. That drop in output means even less blood gets back to the heart muscle itself. This, of course, worsens the oxygen mismatch and makes the heart attack even bigger. You can see where this is going, right? It's a vicious cycle that can spiral down into something called cardiogenic shock, which is often fatal. And this is exactly why all the work done before surgery is so incredibly important. The medical team basically has to become detectives, piecing together all the little clues to build a really clear picture of each patient's unique cardiac risk. Doctors use these special risk calculators to flag the biggest warning signs. Some are pretty obvious, right? A history of smoking, diabetes, or known heart problems. But other clues are more subtle and help paint a fuller picture. Things like how well the kidneys are working, or even if the patient has been on certain heart medications for a long time. It all helps the team get ready for what might be coming. Okay, but what about the dangers you can't see? The heart disease that hasn't caused any symptoms yet? How do you find a problem that's just lurking under the surface, basically waiting for the stress of surgery to bring it out? Well, they've got a whole arsenal of diagnostic tools for this. A SPECT scan uses a radioactive tracer to watch blood flow, but it can sometimes give false positives. A stress echo uses ultrasound to see the heart working under pressure. No radiation, but it really depends on the skill of the person doing the test. A cardiac MRI gives these beautiful, detailed pictures, but it's not an option for everyone. At the end of the day, there's no single best test. It's all about picking the right tool for that specific patient.
Okay, now we're stepping inside the operating room. In here, the anesthesiologist and the surgeon are performing this constant, delicate high wire act to keep the patient's body in perfect balance and protect that heart from the energy crisis we were just talking about. One of the most important numbers on all those monitors is 65. That's the mean arterial pressure, or MAP. The easiest way to think about it is as the average pressure fueling the body's engine. A ton of research shows that if that number dips below 65, the risk of starving vital organs like the heart and kidneys of oxygenated blood starts to climb and fast. And listen to this. It's not just if the pressure drops, but for how long. If a patient spends a cumulative total of more than 30 minutes in that low-pressure danger zone during the operation, it's directly linked to a much higher risk of heart muscle injury after surgery. Every second counts. Now, here's a factor that might actually surprise you: body temperature. It turns out that something as simple as keeping the patient warm, above 36 degrees Celsius, is an incredibly protective measure. It helps reduce blood loss, lowers the need for transfusions, and most importantly, it significantly drops the rate of serious heart complications. It's such a simple thing, but it has a huge impact. All right, the surgery's over. The surgeon did their job. You'd think everyone can relax, right? Not so fast. The danger is not over. In fact, the postoperative recovery period is when many of these cardiac events happen, and a lot of the time they happen silently. Immediately after surgery, the body is in a state of controlled chaos. You've got pain, fluids are shifting all over the place, and there's a huge inflammatory response going on. This physiological storm can both trigger a cardiac event and mask its symptoms. That's why a patient can have a heart attack without that classic movie-style chest pain. So, to find these silent events, doctors rely on a blood test for a protein called troponin, which is a super sensitive marker for heart muscle damage. And the connection shown here is just staggering. A tiny, almost undetectable troponin leak is linked to a 30-day mortality rate of just 0.5%. But when that level is high, the mortality risk skyrockets to nearly 30%. This is definitive proof that even the smallest bit of heart injury after surgery is a very, very big deal. So that brings us to the ultimate solution. A problem this complex can't be solved by one person or one specialty. It takes a vascular team. This is a dedicated group: the surgeon, the anesthesiologist, the cardiologist, the intensive care specialists, all working together, in sync, from the very beginning to the very end. They assess the risk, they navigate the surgery, and they stand guard during that critical recovery period. And that leaves us with a final thought. We often think of progress in surgery in terms of shiny new devices or futuristic techniques, but as we get better at tackling more and more complex diseases and sicker patients, maybe the most critical innovation isn't a new scalpel or a fancy stent, but the collaborative, human expertise of the team itself.